I told you about laryngomalacia. Any congenital cysts or bilateral congenital vocal cord paralysis. The vocal cord goes into adduction. Trauma, direct trauma or due to the accidents, and sometimes because of iatrogenic during doing any surgeries. Then commonest is the thyroid surgery and urinary burns. Any exposure to the fumes can also cause a stridor. Fumes and burns, they will have a reflux edema of the mucosal of the larynx and the trachea. Coming to the inflammatory conditions, the commonest which we can tell first one is the acute epiglottitis, then acute laryngitis, a specific condition called diphtheritic laryngitis, or sometimes laryngeal edema, which occurs due to any laryngitis, can also cause rarely in immunocompromised patients this stridor. The neoplastic one commonest is the papilloma in the adolescent age or children particularly. The carcinoma, which is a malignant one in adult, is the commonest one. Coming to the very rare conditions like miscellaneous, which cannot be categorized, one is the foreign body or direct vocal cord, idiopathic vocal cord paralysis. Another condition which we have to keep in mind always, angioneurotic edema. This angioneurotic edema is an anaphylactic one, or sometimes anaphylaxis due to any medication, or sometimes food. This is also one of the emergencies where, as a Mbbs undergraduate, when you are posted in a peripheral hospital, you are supposed to deal these cases. There is no time to send the patient to any specialist or any tertiary referral hospitals. If you take causes from the outside, that is the respiratory tract, one is the congenital, one is the Pierre-Robin syndrome. Here there is a micrognathia, the patient will have a short chin and other abnormalities which will lead to the stridor. Rarely vascular loops around the trachea or sometimes bronchi can also block the airway. And outside trauma can occur either directly or any chest injuries also, then you need to go for, you observe stridor here. Any inflammatory condition, not in the larynx outside, the commonest one is the Ludwig's angina. Submental cellulitis, which is very common condition, mostly because of the decayed tooth or tooth infection, which extends into the submental or submandibular area and produces gross swelling of the neck, which will extend into the mediastinum also very rarely. Then other condition, which is nowadays rare we are seeing, is the retropharyngeal abscess. Retropharyngeal abscess, both in children, also in the adult, can also cause the stridor here. What are the neoplastic conditions which we see from outside? Is the first one is the enlarged thymus. This is one which we have to keep in mind always when we deal with the stridor, because thymus is mostly forgotten by the surgeons and they search other areas, sometimes will miss it. That's why you keep in mind there is one condition, thymus enlargement can also cause stridor. The next commonest one is the enlargement of the thyroid. Simple thyromegaly doesn't give stridor normally, but whenever there is a carcinoma of the thyroid which infiltrates into the trachea or thyroid cartilages or cricoid cartilages, then this will cause the stridor. Next is the metastatic mediastinal lymph nodes. Any malignancies from the oral cavity, from the lips to the larynx, and also the hypopharynx, these will give metastasis in the lymph nodes where you are having different levels of lymph nodes in the neck. Particularly, these whenever they are involved, they may also cause compression. Sometimes they infiltrate into the larynx and trachea. This is also may cause stridor. There is very rare condition which will be present since birth, or sometimes it appear later in the ages. That is what we call cystic hygroma. This is one condition where there is a small, soft swelling, unilateral one. One side it will be there, but normally, unless it goes such a big in size, it doesn't give stridor. The other conditions like foreign body not in the larynx, in the cricopharynx. When it is present, when it is swallowed, it is has gone into the food passage. Then normally the foreign body is blocked at the cricopharynx. We'll discuss the foreign bodies in the next class. Coming to the history, what are the things you have to take whenever you have seen a patient? How do you proceed it? That is very important. This is why, as I told you from the beginning, it is one emergency. Every doctor has to know how to deal with, how to tackle with, how to give the first aid for this patient. We have to ask the detailed history to detect the cause. See, if the foreign body in a child, then they give my child is playing like this. Sometimes they give a history of congenital, whether it is congenital or acquired, that we have to ask the patient. Because a child has come about 6 months. If you ask them whether it is a congenital, then you can put other diagnosis. It is only stridor is seen since 1 or 2 days, then you can suspect a foreign body. This is one of the most common we come across almost every month. 1 or 2 cases will come foreign body aspirations, particularly in the airway. And the common cricopharynx, of course, almost per week, one foreign body will come to our OP and we deal with. Then you should ask about any patient is having any fever. Fever indicates you can diagnose it. There is a possibility of any inflammation like acute epiglottitis or a diphtheria or any acute laryngitis. These conditions you can exclude retropharyngeal abscess. These are all can be suspected if patient says fever is there. And what type of fever? As you know, another condition called tuberculosis. Tuberculosis, you will have an evening rise of temperature. For a chronic period, tuberculous laryngitis also can cause, and there is a profuse granulations. They are like apple jelly granulations. Then also it can produce a stridor. If the patient says only I have a sore throat, it is only of 2 or 3 days duration, and later I suddenly develop this stridor means you can suspect this is a case of a epiglottitis or acute laryngitis. Then any swelling history, if you examine the neck, find any swelling, then you know already we have discussed about the swelling of the neck that has to be excluded. And what about the change of voice? And there is a change of voice is present for a few days and for a long time, then you can suspect that is a possibility of what you call vocal cord paralysis conditions. Then already I told you any history of foreign body aspiration. Sometimes a child is eating something and suddenly he has a cough, then he develop a choking, then you can suspect a foreign body also. And commonly many people, they leave the child on the floor. They will introduce different types of foreign body which we cannot imagine. We can see, we have seen in our life so many unimaginable foreign bodies also. The clinical examination has to be start from the nose, nasopharynx, oral cavity, oropharynx and hypopharynx, and larynx to rule out any cause in the upper airway. And next you have to examine the lungs. A clinical examination with your stethoscope is the both lungs are ventilated, or have you seen any difference in the lung aeration by your examination with a stethoscope? The cardiovascular system for any anomalous vascular loops. Of course, this you have to go for a different techniques of what you call other whatever CT and MRI. But neck examination has to be done by you. Just to palpate on the both sides and front and posterior. Any masses, anything you can find, you have to note it. Then what are the investigations? The radiological investigations of the neck is very, very important. Then we take soft tissues of the neck, lateral view, and also sometimes we will take anterior view, which we have already described steeple sign and also the thumb sign in the lateral views. And we have to take the X-ray of the chest, whether both lungs are getting aerated well or not. Then you have to take CT scan of the involved site. Whenever the patient says there is a mass in the neck, then you take a CT scan of the neck. We do the direct laryngoscopy if possible, whether you can also do the indirect laryngoscopy. Many times, because the patient is under the stretcher, you have to go for a direct laryngoscopy, whether flexible or a rigid one, and bronchoscopy also has to be done to rule out or to confirm the diagnosis. Nowadays, we are having a fiber optic thing which are smooth and easy to insert into the patient. First, the treatment, you have to admit the patient into the hospital. Whenever stridor, don't advise the patient to go home. Always admit him first. Never say you are safe and you can go home. Admit him first and observe. If you don't want to do any surgical intervention, if you feel that the stridor is mild and you can wait by giving some steroids, if any relief you can expect, then first admit him and then start your treatment. If the patient is having a severe stridor, there is no time, the saturation of the oxygen is getting down and we are losing the patient, then do emergency tracheostomy. There is no need to consult anybody, immediately do the emergency tracheostomy. Nowadays, after the invention of these ventilators, the endotracheal intubation is also one condition, one measure we can take. You can put the endotracheal intubation and put him for ventilator for a while, and you can plan for morning with your other team of your doctors what to be done. But when you don't have an endotracheal tube intubation with the ventilator facility in your hospital, there is no point waiting, go for an emergency tracheostomy. Then here you have to put oxygen, which is a humidified oxygen has to be given. Then treatment of the cause, depending upon inflammation, antibiotics, any allergy, and anti-inflammatory steroids also given. If you expect some masses, neoplasms, then you have to go for a surgical mode of treatment. Now we discuss about the tracheostomy. This is from the very olden surgery. First, Antonio Barsola first performed this operation in 1546. Just imagine. He performed this first operation in the trachea. The first tracheostomy tube, two cannulas, because now we are putting two tubes, was introduced by George Martin in 1730. See, just imagine, it's about the 200 years took to develop a tracheostomy tube. See how slow, and that is important thing is how much time they have taken to modify. We have to appreciate George Martin. Later, again, after 200 years, there is one doctor called Chevalier Jackson. He is famous for our use of endoscopes, our endoscopes, and also the bronchoscopes. And this person has developed a lot of work on the spokes and also the tracheostomy. Chevalier Jackson. That's why one of the tubes of the tracheostomies are named after him. It is 1923. See, there is a lot of time, 200 years to develop in each step of tracheostomy development. The creation of a permanent stoma between the trachea and cervical skin is called tracheostomy. You should know what is tracheostomy, what is tracheotomy. Tracheostomy is a permanent stoma which we will make in between the trachea and the cervical skin. This creation of surgical opening into trachea is called the tracheotomy. Tracheostomy. Tracheostomy is a permanent opening. Tracheotomy. The two terms are, however, in common use and are interchangeable. Only opening trachea is called tracheotomy because we will close the opening later immediately. But creating a permanent stoma for a long time, we call it as a tracheostomy. As already you know difference between osto and otomy in the surgery department. There is another condition called laryngotomy. This laryngotomy can be done at cricothyroidomy or coniotomy, that is opening of the cricothyroid membrane here. Whenever there is an emergency, we do what you call cricothyroidotomy or coniotomy, conus elasticus. The aims and functions of the tracheostomy. What is your aim? First, we have to relieve the obstruction present in the upper airway. I told you, it is the upper part of the lower respiratory tract. You keep it in mind, upper part of the lower respiratory tract. Normally, upper respiratory tract consists of the nose to the nasopharynx. It is a lower respiratory tract, but it is upper part of the lower respiratory tract. We do one for to relieve the obstruction. Second is the bronchial toilet, which we will aim. Bronchial toilet here. You have to clean whenever a patient is not able to clear his throat and going into the lungs. Then you have to aspiration, what we call. Then you need a bronchial toilet. Then this tracheostomy is helpful. Here you have to keep in mind the anatomical dead space. It reduced by 30%. See, whatever the volume there, 150, 500 cc of your tidal volume, there is anatomical dead space, what you call 150 cc is there. This 150 cc is reduced by giving a opening at the trachea because air from the nose to the larynx up to the trachea is saved. The patient need not have a strain to take that air. This is what we call anatomical dead space is reduced here by doing tracheostomy. This reduces the airway resistance. That means the patient can easily take the respiration without having any strain because you have reduced the dead space. And it protects again aspiration. We are having what we call cuffed endotracheal tubes. These cuffed endotracheal tubes, they won't allow the aspiration whenever you give any liquid food or any solid food that won't go into the trachea. They don't develop aspiration pneumonias because there is a cuff for the outside tube at the early stages. Whenever you need assisted ventilation, that's all I told you with ventilators or with your anesthetic apparatus mission. When you want to ventilate, then in surgery or in ICU, intensive care units, then you need tracheostomy when the period is for a prolonged period. Because prolonged period can cause granulomas and change of the voice and other larynx problems. That's why people go for a tracheostomy when more than 7 days to 10 days ICU ventilator is required. Here, the patient will swallow without reflex apnea. Whenever we swallow, there is a moment of apnea will occur. In cases of tracheostomy, there is no need for reflex apnea, particularly the COPD patient, where there is a minimal aeration of the lung area, then the tracheostomy will help. Sometimes administration of the drugs and humidified oxygenation, even general anesthesia. When you do a big operations in the mandible, tongue, then you can't go directly with a normal ventilator. We will go with the opening in the neck with a tracheostomy. We will anesthetize from there, and you complete your surgery. Once the patient is recovered, we'll close the tracheostomy. The physiological changes which will occur is one is the humidification and warming is absent here. That's why you have to give humidified oxygen and also check the temperature where the patient is staying. The patient cannot speak when there is a tracheostomy tube is there. When he wants to speak, he has to close the stoma, then the subglottic pressure increases, the phonation will come. There is a loss of olfaction. Here, the ciliary activity of the mucosa is also dried because there is no humidified air. These patients, because they are having, there is no resistance during inspiration and expiration, that pressures, they're prone for atelectasis. During inspiration and expiration, there is elastic recoil against the resistant pressures. But because there is a air going through the tracheostomy, which these pressures are absent, they are prone for atelectasis. Swallowing, coughing is affected because there is a subglottic pressure is not developed here. What are the types of tracheostomies? Depending on the time, when the patient comes to you, depending when you wanted to do, if you do immediately, we call it as an emergency tracheostomy. But you have seen a patient, you wanted to do some surgery afterwards, but you can't do without tracheostomy, then we will plan for that. Then we call it as an elective tracheostomy. Or sometimes you are given steroids for an emergency patient, he is relieved, then you can plan safely on the next day on your operation theater day for tracheostomy. We call it as elective tracheostomy. And next is the prophylactic. I told you already, when you do major surgeries or the oropharynx, then you will do a prophylactic tracheostomy. Also, sometimes in cases of laryngeal surgery, that is partial laryngectomies and all, then also we do the prophylactic tracheostomy, then we do the partial laryngectomy, then we'll close it later. This is for elective and prophylactic. Emergency, I told you, the immediately the time the patient arrived, you are doing, it's called a emergency tracheostomy. Depending upon the cause, what is the cause for this? Is it a temporary? That means acute epiglottitis, acute laryngitis, then it is a temporary. Permanent tracheostomy, that means you keep the tube for a long time like carcinomas until you finish the radiation, until you finish the chemotherapy, and sometimes you don't expect also totally to remove it, then we call it as a permanent tracheostomy. Then the site of opening in the trachea, whether high or mid or low, we describe. The mid tracheostomy, which is called normally done in the 2, 3, 4 tracheal rings, and high tracheostomy when you are approaching into the 1 tracheal ring, because there is obstruction below by thyroid malignancies or some malignant tumor, then we call it as a high. When above is obstructed, when you go into the lower area, we call it as a low tracheostomy. Based on the technique, see, there is one word we use that is called mini tracheostomy. That is called cricothyroidotomy. We open the cricothyroid membrane, and sometimes what we are doing in the regular is called the open surgical technique. And percutaneous and translaryngeal, these are also classified according to the technique. What are the indications for that? Indications already we have come across is the laryngeal web, stenosis in congenital varieties, tracheoesophageal anomalies. Another condition which we have to keep in mind is the choanal atresia. In the early months, also. And the tumors, what you call hemangiomas, congenital hemangiomas. Trauma, blows on the larynx, cutthroat trees. Normally, this is suicidal or homicidal. We come across a lot of cases. And blow on the larynx is more common we see in the traffic accidents. Foreign bodies, that means during a foreign body may enter into the airway and swallowing of the corrosives. This is another condition where you will come across more this suicidal tendency, corrosives, and inhalation of irritant fumes, which occurs in the accidents in the what you call recently we have seen one accident at the Simhachalam area. These fumes, styrene gases, these can give inhalation of different fumes and gases into the airway and they cause edema and they end up with the tracheostomy. And infections, already we discussed epiglottis, diphtheria, laryngotracheobronchitis. This is one condition I told you. It was very common at one time, acute laryngotracheobronchitis. We used to call it as ALTB, but now it is becoming very, very rare. Last year, I have never come one case, this ALTB. Seen now, but because of development of techniques, management of Ludwig's angina, with good antibiotics and incision drainage, we are managing Ludwig's angina without resorting to any tracheostomy. Very rarely, in 3 years, we did only one Ludwig's angina case for the tracheostomy. Another one is the acute retropharyngeal and parapharyngeal abscess. These are also retropharyngeal and parapharyngeal also. Because of a good antibiotic coverage in our place, these are very rare, but parapharyngeal is seen extending from other areas. And this is also one condition may need tracheostomy rarely. Neoplasms already we discussed benign multiple juvenile papillomata of the larynx, malignant lesions from the tongue, pharynx, larynx, and thyroid trachea. These are all can a spider because I already told you from base of tongue to the major bronch. Then neurological conditions like bilateral laryngeal neuroparalysis, that is mainly recurrent laryngeal paralysis. They give a adductor. All the things will come into the adduction. Then the patient will have a problem of the stridor. And the thyroidectomy, when you injure the both recurrent laryngeal nerve during thyroid surgery, this occurs when there is a big multinodular goiter, or sometimes when there is a extensive thyroid carcinoma going for a resection. Very rarely, I told you the idiopathic condition. Another condition, neurological, is the bulbar palsy. Bulbar palsy. This is one condition where these conditions you see in patients with Alzheimer's disease or in neurological condition. They end up, they can't swallow. And whatever they are eating, that will be aspirated into the lungs. That's why you will put the nasogastric tube feeding. We do the if possible, if required, then you have to go for a tracheostomy. Miscellaneous, I told you, angioneuritic edema. It is anaphylactic edema which has to be dealt. But very common here. How do you protection of the tracheobronchial tree in condition leading to these to control the aspiration, inhalation of saliva, food and blood, gastric contents, and stagnation of the bronchial secretions for aspiration to the lungs. We use this cuffed endotracheal, this cuffed tracheostomy tube. So I will show you how the cuffed endotracheal tracheostomy tube is there. You have to take cuffed endotracheostomy tube whenever you do this technique. I mean, tracheostomy in this type of patient, aspiration, probable aspiration patient. The rare things are bulbar poliomyelitis, tetanus. Nowadays, we are seeing very rarely. And this is one condition, coma, that is very common. Coming with head injuries or intracranial surgeries or some poisonings, we will attend to the neurosurgery department and we do the tracheostomies. I told you another one is the multiple facial fractures. Whenever you do the mandibular and also the maxillary fractures, the airway is compromised, then you have to go for a tracheostomy in these cases first and correct other things later. We will close the opening. Very rarely, the polyneuritis is one condition it can also produce. The condition causing respiratory insufficiency, lung disease like post-operative pneumonia, and also the pulmonary edema, chest injuries during operations involving the chest wall or direct injuries like a traffic injuries or any suicidal injuries that also can produce. Neuromuscular incoordination and polyneuritis, poliomyelitis is also described. Bulbar poliomyelitis, where you have to go for a tracheostomy. I told you already about tetanus. This is one condition, motor neuron disease. This is motor neuron disease is transmitted in the families and they feel, and another one is the muscular dystrophies. These two conditions, motor neuron disease and muscular dystrophies, these two conditions they see at the age of about 50 or 20 years. They go on slowly and motor nerves won't function. The muscle will go atrophy. Sometimes you have to end up for a tracheostomy and later for a few days, maybe also with ventilators. What is the technique of doing tracheostomy? Technique we use normally we do under local anesthesia. It is very common because general already the patient is tired. The anesthetist doesn't prefer to give general because anything goes wrong, the blame goes into the anesthesia. We try to do tracheostomy mostly under the local. It is very usually. After local, sometimes they go for a endotracheal intubation. Sometimes some people they do first endotracheal intubation immediately where there is a ventilator facility. Unless there is a ventilator, no anesthetist will try to go for a endotracheal intubation in these tighter cases. Or otherwise, you will do here and later shift the patient where the facilities are available here. See, then after doing endotracheal intubation, you can do under local again tracheostomy. The position of the patient here is very, very important. The position we have to keep the patient neck and head has to be extended with a pillow placed under the shoulder. The neck has to be extended over the chest. Time how much period you have wanted to keep, you have to use the technique of incision, vertical or horizontal. Then remove cut the skin, later fat, deep fascia, that is platysma, strap muscles are separated. You are having a sternohyoid muscles has to be separated. Isthmus of the thyroid has to be identified and lifted. It is cut. Make a tracheal opening, introduce the tracheostomy tube. This is how we do the tracheostomy. See the patient here you are seeing there, you keep a pillow below the shoulder blades, scapula, the neck is extended, head is extended, and you are infiltrating the local anesthesia. Then I told you, you can give a horizontal incision or a vertical incision. If it is a temporary tracheostomy and the patient is a celebrity where the cosmetic importance is there, normally we give a horizontal incision. But the dictum of the saying, whenever a patient with a struggle, coming with a struggle where there is not much important the cosmetic for the life, then the first thing what we have to do is the give a incision, a notch to notch incision from the thyroid notch to the suprasternal notch. We have to give incision thyroid notch to suprasternal. When you are experienced enough, just you give 3-4 inches below the thyroid cartilage. Then that's why the time permits. We can give a small incision vertical. Then you take out that deep fascia. Then strap muscles are separated here. The thyroid isthmus is identified and it has to be cut. You are having a pretracheal veins which has to be removed and then make a window in the trachea. Making the window also another important one. We have to leave the first tracheal ring, make a window in the second, third, and fourth. You can make a round window like this, or you can give only a straight incision into the trachea. Before confirming whether this is trachea or not, before giving incision, you have to confirm this by taking a syringe with a fluid, a normal saline, put that needle into that tube and aspirate it. If air comes, then you confirm it is the trachea. Many times in the children and where the patient is struggling, moving forcibly, sometimes you will damage the major vessels like carotid. That's why you have to check whether the trachea is identified by taking a syringe with a saline. Just aspirate the contents. If you get air bubbles into your syringe, you can confirm it. Then you can put the tracheostomy tube here into the trachea, and you are seeing here the bulb. I told you, you can give a vertical incision here, simply a vertical incision, where there is a temporary tracheostomy. Or you can separate in between the tracheal ring. That is another technique they developed. In between the tracheal ring, you can give between 2 and 3 or 3 and 4, just give a horizontal incision and introduce your tracheostomy tube. These two techniques are used in the temporary. But when you wanted to do the permanent tracheostomy, you have to take out a bit of the cartilage around, or you can give a vertical incision and take 2 semilunar bits of the cartilage to make the opening into the round. That is important. Then this is the permanent tracheostomy. What are the complications can occur? First complication, which this is one, normally the question comes more on the tracheostomy. The tracheal apnea, also one of the short notes or 2 marks. See that whenever once you open the trachea, the air into the lungs is gushed out. Then because there is obstruction, the carbon dioxide pressure is highly present in the hypercapnia into in the blood, and this pressure, this measured pressure is lowered once it is the trachea is opened. The carbon dioxide is the stimulant for the respiratory center. High carbon dioxide pressure is the stimulant for the respiratory center. Once the carbon dioxide washed out, what will happen? Because respiratory center comes down and the patient will develop sudden apnea. Whenever you see, once you open the trachea, then if you see there is a apnea, then what we have to do? First ideal thing is if you have a carbon dioxide cylinder, introduce carbon dioxide into the tracheostomy tube by putting some tube there. If you don't have a carbon dioxide, then you just take one endotracheal tube, introduce into the tracheostomy opening, and you take into your mouth another end of the tube, and you inhale with your nose inside. Inspiration has to be done. When you expirate it through the mouth into the tube, into the patient's lung. Because in your expiration, the carbon dioxide will come, and this is enough to produce the apnea to be corrected, and the normal respiration will come. If the third technique, if you don't have that facility, just close the tracheal opening for a while. Once you close it, automatically the carbon dioxide tension will become more, and the patient will develop again normal respiration. Next, the complication is the bleeding. Bleeding is one complication where you will see, because you are having a communicating vessels. Anterior, you are having anterior jugular vein, anterior jugular veins are there. These two anterior jugular veins are, you have a communicating branch. This communicating branch can also give sometimes a severe bleeding. Very rarely, one artery is there that is called thyroid edema, which is very rarely present congenital in some patients. And this thyroid edema is also one of the reasons to produce severe bleeding. Then injury to the apical pleura, it occurs more in the children because the pleura will come into the lateral aspect of the neck whenever there is a strain in the respiration. If you damage that, the patient may develop pneumothorax. And another injury to the immediately by the side of the trachea, you are having in tracheoesophageal groove, the recurrent laryngeal nerve, which has to be also taken care. And blood vessels, major blood vessels, that's what I told you. First, you have to confirm whether it is a trachea or not by a saline and syringe. Blood vessels is one is the internal jugular vein. The next one you are having is the common carotid artery. Common carotid artery, and also the either of the branches of it can be damaged sometimes. Then, if you damage, see, when you are opening the trachea, if your blade goes to the posterior wall and cut, then you may damage the esophagus also. And that is one thing. That's why you have to open only the anterior wall of the trachea. The cartilage of the larynx and the trachea also may get damaged further if you don't have a control over your blade. Then aspiration of the food, because sometimes we don't have the cup food tubes. Sometimes patient may aspirate the food contents. The intermediate complications, that is the dislodgement or blockage of the tracheostomy tube. Tracheostomy tube sometimes may be dislodged while patient sleeping. Suddenly in the night he will wake up with a stridor. Or sometimes blockage of the tracheostomy tube. This blockage of the tracheostomy tube is controlled by having two tubes, that is inner tube and outer tube. Inner tube is always lengthier than the outer tube. Because why inner tube is lengthier? See, when you blockage of the tube occurs, you take the inner tube because inner tube will get blocked, no? Then you go for cleaning and washing the inner tube. Meanwhile, the outer tube is get blocked. If it is blocked, then because the inner tube is lengthier, if you introduce back into the outer tube, the inner tube will relieve the blockage of the outer tube. That's why always inner tube should be lengthier than the outer tube. Then sometimes because of this tracheal movement of this tracheostomy tube without having a good umbilical belt which you tie it to the neck, then tracheal erosions may come, or the more tip of the tracheostomy tube may damage the tracheal wall, and erosions later they may develop into granulations, and sometimes there may be chances of hemorrhage because of continuous movement. There are some vessels may be ruptured and air may enter. Very rarely air embolism can occur. And I told you already, a surgical emphysema, collapse of the lungs is also one complication because of this injury to the apex of thing. And tracheitis, bronchitis, pneumonitis, lung abscess, atelectasis. These are all complications of the respiratory distress. And the local wound infection, this is more very common because there is a continuous seeping of the secretions over there, including saliva. There is excoriation of the skin around the tracheostomy tube. And this tracheostomy tube excoriation produces small ulcers, a big wound around the tracheostomy tube. These patients, when there is a tracheostomy tube is a big and a long one, they may produce compression over the esophagus. They complain dysphagia. That's why you have to check the length of the tracheostomy tube, which we have introduced here. The late complications, which we see, the tracheal stenosis, tracheomalacia, that is softening of the trachea occurs when we do the big operations like thyroid surgeries, multinodular goiter, and tumors over the neck. Then what will happen? There is a lot of continuous pressure over the trachea. This may lead to chondronecrosis, and the trachea becomes softer like a paper, like a cloth. It enters into the tracheomalacia. And sometimes, because of this, I told you already, the continuous movement of this tracheostomy tube over the major blood vessel. If your tracheostomy opening has gone to one side, not in the center, this may cause hemorrhage. Whenever you remove the tracheostomy tube, we call it as a decannulation, which we will do in a stage wise. First, we close it, the tracheostomy tube, and we ask the patient to wait for 48 hours. If he is able to take normal respiration, then we will totally remove the tracheostomy tube. In these cases, sometimes the wound doesn't heal. Normally, once you remove the tracheostomy tube, 99% the wound will close on its own. But sometimes wound doesn't close, then you have to do a minimal surgery to close the opening of the tracheostomy by taking a flaps. Tracheocutaneous fistula or tracheoesophageal fistula. When a big you have damaged the posterior wall of the trachea, then esophageal fistula may develop, or sometimes because of the elongated metallic tubes can give a trauma to the posterior wall of the trachea, they end up with a tracheoesophageal fistula. From trachea, from other side of the regular opening, some cutaneous fistulas also may come when there is an involvement of other diseases like tuberculosis or fungal diseases, or sometimes very rarely malignancy also. The aspiration of the contents into tracheostomy tube due to corrosion. See, the patient has given a metallic tube, he goes to home, he won't come for regular checkup, and because of continuous secretions, the tube get corrosion and it breaks into pieces, and these pieces may be aspirated into the trachea or into the lungs sometimes, very rarely. What is the post-operative care you do? The important is nursing and fixation of the tracheostomy tubes by umbilical cord, umbilical straps, which is available, rope-like things. You have to tie it to the neck, removal of the secretion, humidification has to be done. You put a wet glass pieces over the tracheostomy tube to prevent the crustings. And care of the tracheostomy tube, regular checkup has to be done. Decannulation, I told you, no process of meaning. First, block it, observe it, block with some what you call, if you have obturator, you can block it, or other you take a matchstick and put some cotton over that and put into the opening there. What are the types of tracheostomy tubes? We are having two types metallics. This is called Fuller and this is called the Jackson's. Fuller is a biflange. The outer tube is having a split like a two leaves if they are present. These two leaves can be compressed outer tube, and the introduction is very easy in the Fuller's tube. And here also the inner tube is lengthier. Of course, in the picture it is not very much seen. Inner tube is lengthier, and the inner tube is having an opening above here. This opening will produce. See, I can show you here. See, this is a biflange Fuller's tube, and this is a opening. This inner tube is lengthier than the outer tube, and once you introduce it here, because the air goes through the subglottic area also, the patient can speak in the same time when you put a fuller tube, there is no need to block the stoma or tracheostomy tube here. And this is the Jackson tube. This is also the inner tube is lengthier, but it is having a locking facility here. Once you put this inner tube, you can lock it. You just rotate this knob, the inner tube is get locked. And this has a obturator also. When you introduce the outer tube, you can fix this obturator here, introduce directly into the trachea, then remove the obturator, then put the inner tube in situ or there. And the Jackson tube, whenever patient wants to speak, what he has to do, he has to close the opening of the inner tube. Then only he can speak. Or outer tube, he can close it. But normally, we don't ask the patient, don't encourage the patient stay without having an inner tube. Always ask him to have an inner tube in situ. And this is another vortex tube, which is see, this is the vortex tube. This tube is having a cuff here. Once you introduce here, you just enlarge this by giving air into this sideway. This cuff is inflated. Then it is not very much tight, just tight into the trachea so that aspiration is prevented. There are different non-metal tubes like Cortex, which is commonly used here. There are other Chile, Traco, Salpicor. These are other models we are having. There is another airway mask is there, laryngeal mask airway. This is also another technique of giving anesthesia. They put this laryngeal mask over the larynx immediately, and they can inflate this so that this holds the larynx tightly and air will go. But this is more useful only in cases of intubations, but not any laryngeal surgeries, but not regarding the biphasic stridor and all. This is not much useful. Laryngeal mask area that you should know. Tracheostomy in infants and children. It is difficult due to soft and compressed trachea. See, because I told you, you get a congenital defects patients and children, foreign bodies, then it is very difficult to manage these patients. You have to deal very carefully. Children means sometimes we have come across, we have seen surgeons opening the internal carotid or common carotid thinking that it is a trachea. That's why be careful whenever you do a infant and child. Don't leave it to a untrained or early ENT surgeon. Take help of another surgeon so that you will be safe in other hands. Difficult identification because of soft and compressed trachea. And in these children, you get less extension because of the small neck. And here you have to extend the neck a little also. If you extend the neck more, the patient will go into more stridor. That is another problem also. And you have to insert the knife very minimal because it's very small. The diameter of the trachea is very smaller, thinking that like adult, you don't insert the knife. And always cut the tracheal rings from below to the upwards. That means you have to cut the fourth ring first, next third ring, then second ring. Never go from above downwards. If you go above downward, sometimes your knife will slip into the tip of the apex of the lungs and also the major vessel. If you go from below and below to the above, even you will be more safe here. Normally, advise don't remove the piece of tracheal wall. As the picture shows, that's why I told you. You have to give a horizontal incision or a vertical incision, but don't remove a piece of tracheal wall, which may lead into the tracheal stenosis. And avoid infolding of the anterior tracheal wall. Sometimes what will happen? Some people, they will fold it, the anterior tracheal wall. If you fold the anterior tracheal wall, that again may cause obstruction. Always infolding of anterior wall in children has to be taken care of. And selection of the tracheostomy tube, it should be proper length, proper diameter, and curvature. Because this is one very, very important. Unless you select a proper length, diameter, and curvature, I told you they may damage the posterior wall, they may damage the trachea, or sometimes they may enter into the important vessels also. What are the procedures in emergency we are having? Whenever there is a patient has come with a stridor, first you have to use a jaw thrust, jaw forward neck extension has to be done. Oropharyngeal airway has to be taken care. Nasopharyngeal airway also has to be taken care. We are having a trumpet, if you want, you can put it. Laryngeal mask airway. That's what I told you. I have shown the picture. Transtracheal jet ventilation. This is another technique where we use for remove of the foreign bodies. With high pressurized air is entered into the trachea by transtracheal jet ventilation. We are having endotracheal intubation, which we use for anesthesia and also the patients with the ventilators. Cricothyroidotomy or laryngotomy or mini tracheostomy, these are all same. We'll open the cricothyroid membrane here. Next is the percutaneous dilatational tracheostomy. Now a thing has come percutaneous, directly you enter into the tracheostomy, and later you dilate the opening. That is one technique. The popular what we are using called the emergency tracheostomy. This is a laryngotomy or cricothyroidotomy, mini tracheostomy, which we have described. This is the thyroid cartilage, what you are seeing here. And from thyroid, you are having a cricoid cartilage, which is covered with the thyroid gland here. And in between, you are having a cricothyroid membrane. And in between cricothyroid membrane, this membrane had made an opening in this. This is called a laryngotomy or cricothyroidotomy. This is an emergency procedure. Every person has to learn there is an cricothyroidotomy needle is present. It is advised every doctor has to buy it and keep it in your hand so that when you work in the peripheries, at least you can give the airway. Some people they will say even at least you just put a blood needle, blood aspiration needle. If you have a blood aspiration that is 20 gauge needle or a blood transfusion needle which is 18 to 16, if you have just put a needle, that is enough first to save the patient from the respiratory distress. This is laryngotomy steps. Thank you.